So, Dr. Gebbie, I'm Hugh Tilson still, in case I need to introduce myself after over 30 years of friendship. And I can't believe that we finally have captured you in a room. I mean, you're so busy and overall everywhere for this interview. Thanks for joining this series. This is Profiles in Public Health Leadership. Lord knows you qualify. You have the best profile I know. And a leader in every way I can think of. Kristine Gebbie, thank you so much for joining me at this University of Kentucky Center for Excellence in Public Health Workforce interview, because we're going to focus on your work in public health workforce. Chris, let's start off. I mean, you've been in public health for a long, long time. Certainly, our first encounter was your first big public health break when you came out to Oregon to be state health director, and I was Multnomah County, that's Portland, Oregon, health director. And I know where that story takes us. So let's crank back even before that and tell us a little bit about how a St. Olaf's graduate clinical nurse came into public health. What did you do before public health, and what got you to come over to the dark side?
My entry into public health is public mental health. My master's degree is in community mental health, earned at UCLA at the height of the community mental health movement, and the notion that we could prevent some abuses of psychiatric hospitals, some problems with mental health. We were doing crisis intervention, the 6-week walk-in clinics, etc. And that's what I had always wanted to do. I saw the mental health side of care as woefully neglected.
Which it still is.
It still is.
You didn't do a good job fixing that one,
I know, I was terrible at that. We had a revolving door.
What year was that?
That was in 66 to 68 when I was at UCLA working on my master's.
So that was the great Gerald Kaplan community mental health breakthrough period.
Right, and the California mental hospitals were starting to empty out. They were starting to put in real court hearings to prevent abuses of hospitalization, and we were looking at the system, the laws and the structure. And that's always been my metaphor. And I joined APHA at that time to be sure that public mental health was a part of public health.
Isn't that great? But then you went back into hospital nursing.
I went back into hospital management. I taught at St. Louis University Medical Center. There weren't jobs for nurses in the community in St. Louis.
There weren't.
There really weren't. And so I taught mental health, public health, psychiatric nursing at St. Louis University, and we started to create what were then not even called nurse practitioners, but nurse practitioners in the community. I was working with a colleague in cardiovascular nursing, but we set up primary care, primary nurse-oriented, actually joint practices, a primary care internist, a primary care nurse, working with a team of patients. And after I got engaged with running that to try and make it work right, because that was a system, while caring for patients. You know the patients who come to an academic health center with a chart this thick, because nobody wants to talk to crazy Mr. X, those were my primary care patients.
Fabulous.
So but still looking at the system. And I was offered a job as a part of the hospital management team. I took it as an apprentice in management, so I learned how to manage engineering and security and construction projects, and said to myself, I do not belong in a hospital, because everything I was creating in the clinics that made people better hurt the bottom line. And so when I was ready to leave St. Louis, I started looking around for something that would let me continue that prevention, non-hospital based, and Oregon was advertising for somebody to head public health. And I said, why not? And applied for the job.
This is just so important for anybody who's watching this who's thinking of a public health career. Let me just make an observation, see if you agree, that a public health career finds you, not the other way around.
I think that's an excellent way of describing it, and I can think of many people who fit that model. A lot of folks who go out to do good for the world in the Peace Corps, for example, and come home having found public health. A colleague whom we both know very well who went to Africa to do good as a missionary doctor and came home saying, something better has to be done in the way of public health and systems.
He is one of my favorite public health leaders of all time. You're talking about Dr. Lester Wright.
I am.
You know, I ought to interview him, too, for this series. Could you arrange that?
Certainly. Be happy to arrange that.
Do you have any contacts? Is he in your network?
You're going to push me on this one, aren't you? Until
he
I
would be
say,
your
he is my
husband and one of my best friends
Yes.
over many years as
Yes,
well.
and your friend before I knew both of you, in
Well,
fact.
you see, you know, we're not going to get away with any secrets in this
No.
interview. You know
Absolutely
this, Chris.
not.
All right, so I observed just right at the outset a couple of things about you that belong in the leadership annals. The first is that you're a systems thinker. And as you know, one of the critical ingredients in leadership, one of the things we teach in public health leadership, is that you need to think about the system at large. My guess is that stood you in great stead when the opportunity to work in Oregon public health came about. That is to say, it wasn't just something in the abstract, not just, oh, why not? It was, there's a system here, and perhaps I can make a greater contribution. Don't want to put words in your mouth here, but knowing you, I know that would be the way you think. A greater contribution working at the state level than at an institution level, and working at the community level, not internally, and looking at the broader system of health. Tell us how that felt. It was a great step forward or backward, because I was running the biggest health department in the state at the time, so you were stuck with me as one of your local health officers. But how did it feel to take that great step into public health systems at the state level?
It was a bit terrifying, partly because I was coming as a stranger to the state, had to be taught how to say Oregon, so I didn't embarrass anybody.
Yeah, there you go.
It's
not Oregon, you mean?
No, it's not Oregon or Oregon. I had to travel around to get to know it. I was succeeding, if I remember correctly, 6 people in 5 years or 5 people in 6 years. It had been a revolving door job.
Well, our beloved friend Ed Press had been director for over the decade, and then he left. And
he was the senior physician actually when I first came.
Oh, was he still?
Yeah, he was still there. His last year was my first year. But he'd been caught in that reorganization that was common in that era of the early to mid-'70s, which was see public health as a human services job and stick it in an umbrella agency with welfare, child welfare, corrections, vocational rehab.
I thought only physicians could direct public health agencies.
Well, oddly enough, particularly in the West, they talk about a director of public health without specifying in the statute what their discipline is. And having had that huge turnover, the head of the Department of Human Resources, or I'm saying it wrong, DHR, where its initials.
DHR in Oregon, right? Because I was DHS in Portland.
Right.
Department of Human Services. And you were
Human
DHR.
Resources. And he talked to a number of people, and they said, get somebody who's run a system, and a good person to look for would be a nurse. So when they were looking for the job, apparently in the applications that came in, they kind of plucked out people with a nursing background to talk to them. Because for survival, if nothing else, nurses have to know the system. They tend to work in institutional jobs. They tend to be familiar with bureaucracies. And so good nurses do think systems at some level, not necessarily writ large as a state.